Hello everyone, I welcome you all in nursing webinar session today, and we are going to discuss about the very most prevalent disease condition called viral pneumonia and its management. Having said so, let me welcome our clinical expertise, Dr. Kishan, who is just going to join within no span of time, and he is from Yashoda Somajiguda unit, and he is our eminent clinical expertise today. He's our senior consultant and general physician. And let me also welcome our very dedicated nurse manager, who is none other Miss Aruna, who is the team lead for medical surgical ward. And I welcome you, Aruna. So today we are going to talk about the condition on viral pneumonia, and I think we are just going to talk about its prevalence and the disease burden. As you all know, this is the seasonal flu season, and we're just going to understand what are the risk factors and its management. Dr. Kishan has joined, I think, or otherwise we can just go with this slide. You can discuss about the condition. Aruna, you can go to the third slide.
Good afternoon, one and all. I am Aruna, working as a nurse manager in Malakpet Yashoda unit. Today, our topic is viral pneumonia. Let us discuss about pneumonia. It is an infection of one or both lungs caused by a virus, bacteria, or fungi. Coming to the pathophysiology, here the infection starts usually from the upper respiratory tract, which bacteria or viruses usually stick to there. And when the infection shifted to the lower respiratory tract, the lungs will get infection. And then, as we are seeing in this picture, the air sacs in the lungs get infected and build up with fluids.
So, sir, okay. So as you can, yes, sir. I welcome you, sir. Thank you for joining the session. Good afternoon, sir. And we were just discussing about the pathophysiology, like the question or your opinion on that. If we do not treat upper respiratory tract infection, does it, goes into a condition called lower respiratory tract? As you can see, the air sacs are all filled with, and it is narrowed. Your opinion or your view, sir?
See, viral pneumonia, for most viruses, it's symptomatic. We don't have effective antivirals. Let's say influenza, we have oseltamivir, which may be of some help. So it is, and viral pneumonia, viral infections, not viral pneumonias, viral infections. The upper respiratory tract infections are so common, and we really don't test them for which virus we are dealing with, because often they are self-resolving, they're mild, right? Yes. But if they're not improving, as just upper respiratory tract infection, they should not have SOB, oxygen level should not drop. So if they're not improving as we would expect otherwise, if they're not worsening, when we suspect that what is just an upper respiratory tract infection is like probably affecting the lungs, then you need to quickly evaluate them with the Xray, CT, or the testing with a swab, and then start antivirals immediately. Otherwise, it's such a common infection, viral upper respiratory tract infection, we just give them symptomatic treatment. We make a clinical diagnosis, probable viral upper respiratory tract infection. We don't usually test them, right? But patients who are very sick on immunosuppression, or patients who are not improving, who have SOB, shortness of breath, then we evaluate them further with imaging, the swab tests, and then add them on antiviral therapy. Start them on antiviral therapy.
Let us see the causes of viral pneumonia. As of we know, influenza viruses, which is H1N1 and H3N2, etc. Respiratory syncytial virus, most common in young children.
And sir, again, here we would also like to know why this RSV syncytial virus is common among younger children, just because of their immunity factor, and anything else? Or
no, it is just the predilection. I think it is that, the immunity factor, as you've rightly said. Children have a different immunological system, and some viruses, kind of commonly seen in certain subset of patients, because that their immune system is probably not just the immune system, the natural barriers, whatever in the respiratory tract, they predispose to certain viruses. But of late, they've been a lot of RSV seen in adults also. It's like it is mentioned here, RSV is usually seen in children. They get the bronchiolitis, right? Very small children very often. Influenza can affect any age group. Yeah, but off late in the last epidemic like this flu season, there were a lot of patients with RSV also besides influenza. But we don't usually test for RSV. It's not easily available. Some labs do offer, but we've seen a lot of RSV in adults as well this year.
So keeping RSV, we might anticipate and we begin the treatment, I think, as for the same, I guess, sir.
Yeah, see there's no effective antiviral, right? So it's again symptomatic and supportive treatment. For influenza infection, we have oseltamivir, but that also is not like a wonderful drug, like an antibacterial agent. They are not. It's finally the immune system of the patient that needs to take care of the infection and other supportive management. Like if they have pneumonia, if they have hypoxia, until their lungs recover, we need to support them with whatever oxygen therapy or ventilation, etc., whatever that is required.
Let us see the risk groups of viral pneumonia are infants below age of 2 years and elder and children, post-organ transplant patients, elder groups above 65 years, pregnant women with infectious diseases like HIV or AIDS, under immunosuppressive or on chemotherapy medications.
And also, I think you might be receiving a lot of outpatients who are on the immunosuppressive drugs and who are chemotherapy users, and what precaution they should be taking, like when they are on this kind of drug regimen.
Yeah, so this takes us back to the first question: whom do you treat with antivirals or evaluate them? So these are the patients on immunosuppressives. They are the ones, even if they come with upper respiratory tract infection, we need to be very careful. We need to caution them that if you have this, these symptoms, check oxygen levels at home. If you feel shortness of breath while walking, just come back to us immediately, because they are the ones who are likely to progress very fast. Or what is an upper respiratory tract throat infection tends to progress pneumonia. In pregnancy also, the first thing is vaccines. Influenza, we have an effective vaccine available, right, which covers both the influenza B and the H1N1 strain, influenza A. So it is not too expensive. It's an annual vaccine. So first thing is that. So in people who require immunosuppression, pregnant women, elderly people, especially with diabetes, chronic kidney disease, they must have flu shot, because you don't have vaccines, effective vaccine for all the virus, but at least for influenza virus, you have a good vaccine available.
So you recommend to have them take the shot annually?
Yes. Yeah, we recommend pregnant women. Pregnant women routinely are given tetanus or Tdap, right? But pregnancy, if they develop viral upper respiratory tract infection, the chance of them worsening or developing a pneumonia, lower respiratory tract infection is high, 4 times higher when compared to non-pregnant women. So pregnant women also, we encourage them to take flu shot. People who are on various immunological conditions or cancers requiring immunosuppressive drugs, we must encourage them to take vaccines. And similarly, elderly people with comorbidities or without comorbidities, anybody above 60, we should ask them to take flu vaccine every year.
So coming to the common types, here we can see the few common types, which is community acquired pneumonia, influenza, which is influenza, healthcare associated pneumonia, which is MRSA, hospital acquired pneumonia, which is it is also known as nosocomial infection, the ventilator associated pneumonia of ventilator patients. Coming to the symptoms, the common symptoms of fever and chills, weakness, myalgia, sometimes low body temperature, loss of appetite, SOB or rapid breathing, malaise and muscle ache. A typical symptom of cough is that producing green, yellow or bloody mucus.
So, sir, apart from this mentioned and listed symptoms and typical characteristic of cough, do we also get to see patient with some different symptoms?
Yeah. So sometimes even this viral, like, flu, influenza infections, they may have gastrointestinal symptoms like diarrhea. Just because they have diarrhea, vomiting doesn't, mean that it cannot be a respiratory virus infection. They can have other symptoms. Elderly people with high grade temperature, they can become a bit drowsy also. They can become delirious, especially elderly, right? The same thing in small children. They can even have febrile seizures, irrespective of cause of thing. Those are some things you may see even with influenza infection.
Coming to the other contributing factors, who all are working in hospitals, factories, they are prone for occupational hazards, and chronic smokers, history of viral infection, Those are asthma and heart disease, etc.
Yes, continue.
When the patient comes to the hospital, the first step is need to take initial assessment done by doctors upon the admission, and also they need to do chest examination by auscultation to know the abnormal lung sounds of crackles, rhonchi, wheezing, and stridor.
I think we also have forgot to mention about the abnormal sound called crepitus. I think that is also heard, I think, sir, if you agree.
Crepitus is to be honest, it is rarely seen. When there are very coarse crackles, when you put your hand on the chest, you may actually feel that. Other thing is, crepitus is when you have subcutaneous emphysema, right? Otherwise, in pneumonia, we usually don't get crepitus. It's usually when there is air in the subcutaneous, when they have pneumothorax and air is leaking into the subcutaneous tissues, you just keep your hand, you can feel that crackling under the skin. That's crepitus.
Let us see the nursing initial interventions for the viral pneumonia. The first, we need to send the blood investigations like CBP and blood cultures, etc. And inflammatory markers like RT-PCR, H3N2 and H1N1 need to be done as per the doctor's order.
So I think, sir, these are the initial nursing interventions as prescribed and ordered by you all. Anything else you want to be told to the nurses that what precaution also they should take?
So anybody who is admitted with suspected viral pneumonia, like as rightly mentioned, we do basic blood works, right? The blood counts and renal function test, sugar. We always check their sugars. Sometimes they may be undiagnosed diabetics. And inflammatory markers like CRP, we usually do so that, as the patient improves, we see if those markers are also improving. That will also help us to see if the patient is improving, not just clinically, but laboratory-wise. And this RT-PCR is actually the diagnostic test, right? For viral infections, what we commonly use an RT-PCR because it is very difficult to culture these organisms. And culturing a virus, unlike the bacterial cultures, is done only in the research laboratories, right? So only thing that is these patients require isolation, right? Anybody with viral pneumonia, whether they're in ICU or in the wards, they need an isolation. They can't be in a general ward. And the droplet precautions. That is, and both the aerosol route, we have to wear a mask. We have to if the patient is not breathless, at least we need to encourage them to wear a mask. And the people who are caring for the patient, both the attenders and us staff, we need to wear a mask. And then the droplet precautions, hand hygiene is very important, right? That's how they spread, right? Most of these viral infections by aerosol route and the fomites, droplet spread, etc.
And also we need to do chest X-ray for mild inflammation. Ultrasound chest and HRCT is required in case of severe effusion.
I think, sir, this is also the right intervention in case of mild infection, the X-ray, and in case of mild
if the patient is very, very sick, right? Patient is, requiring oxygen, very sick. Sometimes because X-ray, CT chest is like you're having multiple X-rays, right? Multiple cuts. So what X-ray does not pick up, the CT picks up. Because for many viral pneumonias who are requiring oxygen, X-ray may appear normal actually, but the patient's oxygen levels are low. That's when we order a CT, and CT will show you like multiple, opacities, patchy opacities, usually on the CT scan. A significant effusion can be picked up on the X-ray. Mild effusions can CT, even if they are small effusions, CT will pick up, or even the ultrasound can pick up the effusions.
And also we need to check complete vitals and do the ABG for checking of respiratory acidosis and alkalosis to need for oxygenation.
So right amount of oxygenation or the intervention about the same as, because the impaired gas exchange is happening in this condition. And I think the need for hypoxia intervention also is, I think, required for this ABG parameter.
Right. Anyway, we just do a baseline ABG or, depending on how sick the patient is once a day because acidosis, alkalosis, but the oxygen levels, we usually go by the pulse oximetry, right? The peripheral oximetry. But the ABG will tell us the PF ratio. So that way we can adjust what FiO2 the patient requires on the ventilator if the patient is sick.
Coming to the medical management, oxygenation and BiPAP can be administered as per the doctor's advice. Administer IV fluid as per the doctor's advice. Plan for ICD insertion or pictal catheterization if fluid increases in the lungs.
So I think the indication for ICD insertion and pictal is only about when you said the patient is sick and massive effusion and all. I think.
Yeah, massive effusion. See, if suppose viral pneumonia with mild effusion, there's no point. No, so it's only the fluid that we can drain, which is outside the lungs and compressing the lungs. Right, patient already has pneumonia, damaged lungs, but there is a lot of fluid compressing the lungs. Then we insert an ICD to drain the fluid. Or if it's a empyema, there is pus in the pleural cavity around the lung. That's another place where we put a pictal or ICD. Both serve the same purpose, basically.
Coming to the medications, medication which we can use for viral pneumonia, think like means it is an in high risk nature. So as like high risk medication, we need to cross check for these medications like antiviral, antibiotic medications, antipyretics, analgesics, and corticosteroids. For bacterial infection, methylprednisolone or salmeterol, we can taper the dose as per the instructions.
So I think, sir, you go with this order only. I think this is the prescribed medication.
No, antivirals, it depends on which virus. Like acyclovir is for cytomegalovirus infection. CMV, cytomegalovirus pneumonia, is usually rare, seen in patients on immunosuppression post BMT, bone marrow transplant or renal transplant, etc. Fluvir is oseltamivir, which is used for influenza infection. Antibiotics are generally not used in viral pneumonias, but many times because of the viral pneumonia, viral infection of the lungs are damaged and there may be superadded bacterial infection. If the blood counts are high, we think there is, patient initially came with viral pneumonia, but there's probably superadded bacterial infection because the sputum grows or the Xray wise, there is a suspicion of bacterial pneumonia as well besides viral pneumonia, then you would add antibiotics. Steroids are given for viral pneumonias, but in bacterial infections, generally we avoid steroids unless there is a specific indication. They are in shock, septic shock or something. In bacterial infections, if they are in septic shock, we give them steroids. But otherwise, bacterial pneumonias per se, generally we avoid steroids. In viral pneumonias with severe hypoxia, there are some benefits with steroids. So we add hydrocortisone or other form of steroids for severe viral pneumonias.
So coming to the nursing care, we need to monitor the vitals as well as assess the pain, oral hydration or administer IVF, check airway patency, and suction if requires, monitor IO chart, intake and output chart and documentation to be done. Encourage to the patient for deep breath exercises and chest physiotherapy. Will provide small frequent meals and position to the patient semi follows by head up. And escalate in case of desaturation or respiratory distress. And when we are administer nebulization as per the frequency, encourage the expel cough to the patient and rinse mouth after Budecard nebulization to prevent fungal infections.
Do you also want to wish to convey any other nursing care, particularly because you keep looking at the practices of nurses and especially about the nebulization practice and early warning signs, if at all the patient is admitted in the room scenario, sir?
Yeah, actually, I mean, you are the experts at it, the nursing care part. Only thing, let's say if the patient is in isolated room, it's fine. Generally, like if you see in Western countries, people with COVID or influenza, they try to avoid nebulization. If the patient is like conscious or not, they give them inhalers because when you give nebulizer, it kind of produces aerosols.
Yeah, yes.
So yeah, so that, but we don't have that option. If the patient is on ventilator, but that we do give nebulizer. It's a closed circuit. If the patient is on ventilator, it's not a problem. Otherwise, if you're viral pneumonia patient, if you're nebulizing, he should be in an isolated room. People who are caring for him should wear a proper mask because it produces aerosols. Okay, so that's the only thing about that. Only thing, patients on ventilator, be it viral pneumonia or some other pneumonia, you obviously have a checklist. If the patient is like, is breathless or SATs are dropping, then just make sure the ventilator is all right, the connections are all right. Sometimes there'll be a leak somewhere and then suddenly oxygen drops. I'm sure that you all look for something, right? You see if there's any disconnection, all that. Along with your standard measures, always look at ventilator malfunction and any tube leakage or disconnection. You also keep in mind when a patient suddenly deteriorates unexpectedly.
And we need to teach the patient about hand hygiene and explain the patient attenders for limit visitors. And also, if patient is having more than 1 or 2 degrees temperature, we need to provide the tepid sponging. Encourage for early ambulation is required for better outcome.
So I think, sir, early ambulation for the room side patients are also very important because they get to see the improvement, and it is very effective.
Yeah, and psychologically also it makes them feel, gives them a positive, they become more hopeful, they become more positive. And obviously, otherwise, if we don't ambulate them, then they're at risk of bed sores, etc. So that's also important. Obviously, that is difficult in an ICU setting, but once they are about to be shifted to the room.
So we have, I think, almost come to the end of the discussion, and I think preventive strategies, good hygiene practices, as you were mentioning, avoid touching the nose or this part, and adequate sleep, exercise, which will again aid in recovery, eat plenty of fresh vegetables, maintain physical distance, and visit the hospital before it worsens. And we would like also you to convey to the messages to the viewers, like the role of vaccination. I think, as you were saying, the role of vaccination and over-the-counter medications are very, very, taken up when they see they are bound to upper respiratory tract. So what is your message to the community, sir?
Yeah, so basically for upper respiratory tract infection, not everybody needs to rush to a doctor, but 3-4 days they're not improving, fever is persisting, or they have any shortness of breath, right? While walking, then they must visit a doctor. But people who are on immunosuppressants, people who are very elderly, pregnant women, even if it's just an upper respiratory tract infection, I think it's worth they contacted. They're in touch with a healthcare personnel, be it a nurse or a doctor, so that they're monitored, and then any worsening, then they are brought in and then evaluated and then managed appropriately. Vaccination is something which is kind of undervalued, especially in our country.
Yes.
See, the flu vaccination rates are abysmally low in our country when compared to Western countries. So we need to create awareness that, there is influenza vaccine available, which needs to be taken every year. Not too expensive. Not everybody needs to take, but pregnant women, elderly people, people with comorbidities, people on immunosuppressants, it's worth the money for them.
So I think we have done with the session, and thank you so much, sir, for very simple and very delighted information you have provided to the nursing fraternity. And thank you. We end the session here. Until next Thursday, we will again connect. Stay safe. Thank you. Thank you, sir.
Thank you for the invite. Thank you.